like to introduce Louise Papps. She's a Respiratory Linkage Program Coordinator, registered nurse. She has worked for 10 years as a respiratory nurse in a variety of clinical settings, both in the UK and in Australia. She currently works as a community-based respiratory nurse specialist in Perth northern suburbs. Her role incorporates clinics, home visiting and supporting community physiotherapy staff who deliver pulmonary rehabilitation at Linkage. Louise assists clients to understand and effectively manage their condition, aiming to reduce disease progression and improve quality of life. 2 years ago, she established a respiratory support group for people with chronic lung conditions.
So I thought today we'll just go through some, can you hear me at the back? Review respiratory anatomy and physiology. I apologise if I'm teaching the subjects, but I think it's important to just go over things. Define COPD, symptoms and diagnosis. I'm mostly going to focus on the management because I think this is where we really make a difference. And then we'll just talk over some other considerations. Excuse the nasty smell in here, but that's what I'm fine. The function of respiratory system is really for gas exchange, so to deliver oxygen and to remove carbon dioxide, which are waste products. And ventilation is the process of inhaling and exhaling air. So gas enters, and the gases enter and leave through the mouth, nose, pharynx, trachea. The trachea is actually reinforced by a C-shaped cartilage. And at the back it's got a solid muscle, so that allows the trachea to actually change diameter. Going down to the right and left main bronchi, and then the bronchi divide into tubes called bronchioles, which become progressively smaller and smaller, ending in the alveolus. Okay, so the lungs are suspended in the pleural cavity, the thorax. We've got the pleura, which is it's a thin membrane, or two thin membranes. You have the visceral, so the visceral layer lines the surface of the lung, and the parietal is the inner surface of the chest wall. In between those two surfaces is what we call pleural fluid, and that helps the lungs to move freely, so we're avoiding any friction there. So we know that there's 3 lobes on the right and 2 on the left. So the right lung is slightly larger, and that's the dominant part. Now the defences with the respiratory system. So we've got the nose, that's the first line of defence, it's got hairs called cilia. And from there, moving down to the trachea and the main bronchi. There's epithelial lining there and goblet cells. Okay, so these goblet cells actually are the cells that produce the mucus. We've also got cilia, which Pam mentioned, and they're hair-like structures. They're constantly flapping. So the idea is that if we inhale a foreign body, foreign particle, the mucus will trap that, and the cilia actually help to waft that foreign particle up to the point where we can either cough it out or swallow it. We actually produce a litre of mucus a day. That's an healthy process. It's always happened. And smokers actually, those cilia become paralysed, so that function is lost, which is why they cough a lot. So moving on. Main muscles of breathing. So inspiration and expiration. So in inspiration, we have the diaphragm, which is a dome-shaped muscle that sits below the lungs. And we've also got intercostal muscles, so the muscles in between the ribs. So during inspiration, those muscles contract. The ribs move outwards and upwards, the diaphragm flattens, so we have that net effect that the lungs become bigger. That actually produces a negative pressure and air rushes in, so that's how we inhale. So an individual at rest will process 12,000 litres of air a day through their lungs, so it's a massive amount. And through expiration, obviously those muscles then relax and air comes out. So here's the little alveoli. So this is actually where the gas exchange takes place. So alveoli actually, the word alveoli is derived from the Latin word meaning little cavity. So these are the terminal end bronchioles. They're grape-like structures or sacs. We've actually got 300 million of them in a healthy person. I have seen text that says 700 million, but it seems to be the one that's liked is 300, so we're sticking with that today. And if you were to stretch those out, the surface area supposedly would be the size of a tennis court. So it's a huge, huge, huge network. Each of those alveoli has a capillary network around it as well. So as I said, it's the area where gas exchange takes place, and that takes place by diffusion. So you breathe in the air. So air is breathed in, passes down into the alveoli. Oxygen passes from the alveoli into the capillary system and around the body. And then also with CO2, carbon dioxide, our waste product, that comes to the alveoli where it's passed into the alveolus and we breathe it out. Okay, so that's it. Right, moving on. So this is what we're here for, COPD. Again, I'm really passionate. Papps said she was about her. It's not a sexy condition either, but there is so much that we can do to help people with this condition. So the symptoms of COPD commonly develop over the age of 40. It's a major cause of morbidity and mortality worldwide. So this is taken from the Gold Initiative of COPD. So it's common and largely preventable. We've got fixed airflow or persistent airflow limitation, which is usually progressive. And that's the key with COPD, it's fixed airway obstruction. It can be associated with enhanced chronic inflammatory response in the airways and the lung, and exacerbations and comorbidities contribute to the overall severity. So frequency of exacerbation has an impact on disease progression, and that can lead to further decline in function. It's got a very large part of COPD is a systemic component as well. It's not just about lungs. So you can get that increasing shortness of breath. Understandably, people that experience it, particularly in the more severe cases, they're trying to avoid that sense of breathlessness, so they avoid doing things that are going to make them feel like that. So eventually, over time, those muscles become weak, they find that they can't do as much, and then they become more breathless. It's this downward spiral, we call that deconditioning. So what are the risk factors? We all know smoking is the main one. It's about 80% of people with COPD causes smoking. Only actually 20% of smokers go on to develop COPD. Are you familiar with pack years? Pack years, that's how, so we work out if someone's has a significant pack year history or smoking history of what a pack is. And that's actually calculated by the number of cigarettes smoked, divided by 20 and times that by the number of years that they smoked. So a pack year of above 20 seems to be significant. Dust and chemicals is the next one. So occupational exposure. And that could be farming or anything where someone is exposed to chemicals or dust. Biomass fuel, environmental. 3 billion people worldwide use biomass as their main source of energy. So you can see that that's still going to be a major issue. Childhood respiratory infections. And alpha-1 antitrypsin deficiency, that's a genetic disorder, and it mainly affects the lungs and the liver. Only 1 to 2% of people with COPD have that. That's their cause. So moving on to COPD. So COPD is an umbrella term, chronic obstructive pulmonary disease. It includes chronic bronchitis and emphysema. The reason they club them together is because often someone will have a bit of emphysema and a bit of bronchitis. It's not always clear cut. And ultimately, at the end, the main thing is that there is that obstruction there. That's what both of these conditions lead to. So chronic bronchitis, the term is a productive cough for at least 3 months of the year for 2 consecutive years. So we have inflammation on the left-hand side here at the top. You can see there's a nice healthy airway, nice and open. On the right-hand side, you can see that those walls have thickened. We've got an increase in goblet cells that produce the mucus, and the net result is the narrowing of that airway. These people are at risk of infection, so sputum clearance is really important for them. Emphysema. So recurrent inflammation is associated with release of enzymes from lung cells. Inflammation results in elasticity and the airways eventually collapse. So the air becomes trapped in the alveoli, can't get out. And over time, those alveoli become boggy and distended. So that air trapping is the reason why you see this. We talk about hyperinflation. You get pockets of air that are trapped inside the lungs. And over time, we talked about the diaphragm being a nice dome-shaped muscle. Over time, that can actually become quite flattened. So if you look at someone's chest X-ray, rather than that nice dome, it's flattened. And they also can have that barrel chest that we talked about earlier. So if you think about that nice big tennis court that we had, this is probably now, it could be the size of a squash court. You know, the surface area is dramatically reduced from gas exchange. So what are the signs and symptoms? Dyspnea is the most common one, and it's usually the first symptom. And exertional dyspnea. People will often complain that they start to feel breathless when they're walking up hills or stairs. They're not keeping up with their friends quite as well as they used to when they're out walking. Chronic cough is common. Sputum, they may or may not have sputum, depending on whether it's more an episotic condition or bronchitis. We talked about that reduced muscle, or work muscle wasting, which can lead to reduced exercise tolerance as well. And it's really hard for these people to breathe, so they really do have to struggle, and a lot of them do suffer with fatigue. If you were able to take a breath in, and then take another breath, and now try breathing at that level, that's what these people have to deal with every day. That is just a breath. So you try and think what that's like when they then go and try and make a bed or to walk down to the shops or something. It's really, they do have a lot to contend with. So the prevalence is actually so common. And I'm sure we're just hitting the tip of the iceberg here, but it's said that 1 in 7 Australians over the age of 40 have got COPD. It's the second leading cause of avoidable hospital admission. So this says it all. We're not doing enough. It's not enough just to go and give somebody an inhaler, say you've got COPD, off you go. People need to understand their condition to actually start managing it effectively. And I think that's up to us really to start helping them to do that. And it's also the 4th leading cause of death worldwide, which is really sad when it's it's preventable. So going on to diagnosis, we've talked about all the symptoms here. So somebody comes to see you, they complain of dyspnea, wheeze, chronic cough, maybe sputum production as well. We then need to look at their risk factors. Have they smoked? What their pack is? Have they worked with any chemicals or fibres? Have they had childhood infections, or is anyone else in their family that's suffering from those childhood infections? We can't do a diagnosis for COPD just based on symptoms alone or a chest X-ray. They need to have spirometry, and that will ultimately tell us whether or not there is obstruction there and whether or not it's fixed. So that's what needs to be diagnosed with spirometry. And I think you're doing that session later on this week. This is a really useful tool. This is something from the Lung Foundation, and I should all have it in the packs there, so we'll be a bit clearer than this. So this is a stepwise management for COPD. It's a really good plan. So we have, COPD is actually classified into mild, moderate and severe, and that's based on a person's FEV1 or forced expiratory volume in 1 second. You'll learn more about that, but that's the initial blast out when we do the lung function. So it's from full inspiration, they blast out that breath, and within the first second, that's the measurement where we get the FEV1 from. Okay, so an FEV1 of above 80 is normal. So 60 to 80 is mild disease, moderate 40 to 59, and severe less than 40. Okay, and here we have non-pharmacological interventions and pharmacological interventions. Again, I'm not going to go into this because you've got somebody talking about respiratory medications later on. So we're going to focus on non-pharmacological today. So, condition education. As I said before, people need to understand their condition. Lung Foundation have got some fantastic resources, and there's so many people, even the oldies now, that have internet access. So send them off to the Lung Foundation. It's a good reputable site. They've got really good information there. You can actually get booklets as well. They do come at cost. there's different ones, but I tend to use this one. It's called Savoury Breath. I think that's also mentioned in the brochure at the back. It's not too, there's another book, but it's quite in depth, and I think it can be a bit overload for some people. So this is nice, straight to the point about what people need to do over general management. So if anyone wants to grab that at the end, feel free, but I do need to have one so you can apply for it. Smoking cessation. Should I quit? Long and short of it is yes, surprisingly. Having said that, it's such, I used to smoke, I know how difficult it is to give up, and it can take some of these people years, literally, to give up. And some people, I hear stories that, you know, they may have been in the forces, they were given cigarettes in their ration packs, or a GP told me to smoke to clear my chest. You know, and unfortunately these things have happened. Some of us, like me, are just stupid. But at the end of the day, you need to be there supporting these people to try and quit. So if it means going to see the GP to help them with, maybe they need some sort of medications to assist them in that process, fair enough. Unfortunately, I don't think there are any groups or support groups for that anymore, although there are some online services that they can access. So this shows us the person's FEV1, so that lung function again, and the person's age. At the age of 25, our lung function naturally starts to decline, and that's this top line here. It's quite early, really, 25, isn't it? And you can see this line here is someone that is susceptible to the effects of smoking and COPD. So although if they stop at the age of 50, they're not going to regain the lung function that they've lost, but that rate of decline will slow to that's a non-smoker. So it's always worth them giving up smoking. I use this quite a lot with patients. It just helps them visualise. Sputum clearance. We've talked a lot about sputum clearance. But again, it is really a useful tool that physios might be able to teach them. The active cycle of breathing to help remove those secretions. So the coughing, these people that are breathless all the time anyway, the coughing can be absolutely exhausting for them. So if we can help them in any way to find an easier way of keeping their chest clear, then that's what we'll do. The other thing to mention to people is if they're dehydrated, their sputums are going to become a lot thicker. So just to bear that in mind that they should, are they dehydrated. Action plan and exacerbation signs. You've all got an action plan in your packs. Is anyone familiar with these? Do you use them? Yeah. Again, I apologise for those of you that do use them. This is a Lung Foundation one. It's been fairly recently updated. There was a blue one before. So at the top here, we've got when a person's condition is stable, and they would write in here what medications they normally would take. Okay, so that's plodding along as normal. They're normal day-to-day variations that they get. In the second box here, the orange, that actually is when they start to develop symptoms. So they may be more breathless than normal. They may have a cough, which is more productive, or their sputum might change colour. In that instance, in here, we would write, well, it's up to the GP or specialist really to be writing this, but we can encourage it. Antibiotics plus or minus steroids, depending on what their plan is. So this is something that's used for people that are frequently exacerbating. There's no point giving it to someone if they're not having problems with it. It's just something else for them to worry about they don't need. It's been really useful for people. What will happen is Friday afternoon someone starts to develop their symptoms. They might get a nasty cough. They can't get to see their GP till Tuesday, and by Tuesday they've got a rip-roaring infection and they may be in hospital. There is a risk that every time they get an infection there could be more lung damage as well. So we want people to be recognising those symptom changes and to be able to treat it quickly. So the idea is with this, the GP or specialist could write a prescription of antibiotics and or steroids that they can keep at home on standby. So as soon as they notice these symptoms developing, they can get onto them. So if it's an infective exacerbation, that's when obviously they would have the antibiotics, maybe steroids. But if it's a non-infective exacerbation in that there's no signs of infection, but they've got a sudden deterioration in their breathing from their normal, then it may be just the prednisolone that they need to go on. And the dosages of prednisolone seem to vary hugely between doctors, so whether it's 25 milligrams or 50, but we've got to respect that, and that, that's their plan, that's fine. I'd rather they had a plan. And the last one in the red is when things go really pear-shaped and they need to be phoning an ambulance. Okay. But they really have been well received by the patients. It just gives them a bit of an ability to manage that condition independently or with support. So, inhaler technique. Again, I think, have they got a session on? Yeah. So I won't go into it too much, but it's so important. Even someone with the most amazing technique, particularly with the MDI and spacer, you're not going to get a massive amount of drug. We always encourage people, if they're using an MDI with contrast, you need to use a spacer with it because you're going to get much more drug deposition. And that's what this one shows you here. This one at the top is somebody just using a MDI on its own. Those particles, they're travelling so fast, the majority of them are going to hit the back of the throat and end up in the tummy, which is just pointless. So by using the spacer, it's actually going to go to where it's needed. Slow those particles down and actually breathe them in. In addition to that, the space is for people having inhaled corticosteroids, it's going to reduce the likelihood of side effects. So if they're complaining that they're getting thrush frequently, use a spacer. If some people might complain with the oral corticosteroids that they're getting a hoarse voice as well, so in that situation, gargle with water. Another thing that I've come across, just while we're on spacers, washing them every 3 to 4 weeks. We don't want people washing them all the time, and when they wash them, they should just wash them in soapy water, not to rinse them and just leave them to drain. As soon as you start rubbing them to dry them, it builds up static, and then the drug sticks to the device, so they're going to get less drug. So that's the reason. The main thing is with those especially the big volumatic spaces, is that the valve is working. So if you hear that rattle, then it's okay. Has everyone seen the breather? So it's not just the MDIs that we're thinking of. We ask patients about their technique. Even if they haven't got their device, I will get them to show me or demonstrate how they would probably use it. So as you know, this one's got a capsule. Just of note, actually, while I'm cleaning, that pushes out there as well. Okay, so get your patients to actually, and it's really stiff to begin with, but they can wash that in soapy water about once a week and then just leave it to dry. It's only once a day, this one, so if they do it as soon as they've had it, it'll be dry. And this should be replaced once a year. But I had a gentleman in clinic a while ago, and I got him to show me how he took his breather. He said, I don't need my device. I just get the capsule, take it apart, and then have it from my hand. Yeah, I know, but people do all different things. That's why I'm saying it's so important just to check with people. Yeah, I think a lot of money goes into how these things work, so there's a reason. But yeah, basic things you can probably get in another drug. There's also, if you're struggling with technique or want to revise it, the Asthma Foundation have got videos on their website that you can access that show all the different devices, which is quite good. I should also put on there oxygen, because that is a drug as well, so it's not just the inhalers. A lot of these people do have oxygen at home, so going through that, making sure they're using it as per the prescription. Again, we see people doing all sorts of strange things. One of the common things I see with people when they've got the long, have you seen the concentrators? So you've got a machine this high that actually brings in the room air and gets rid of the nitrogen and gives it the oxygen. But that tubing can get really tangled. It's a really basic thing, but all of these people are elderly, and having tubing tangled across the floor is a trip hazard. There's a really basic device called a swivel connector that would fit in between those, and it stops that from happening. But they don't routinely give them to people. But if you're aware of it, you can just say, is the tubing becoming tangled? Is it a problem? Then that's something else that can be easily solved. Okay, vaccinations, we've talked about those already today, but annual flu vaccinations they should be having, and pneumococcal vaccinations is, I think it's still every 5 years. Usually people just have 2. It is encouraged. Pulmonary rehabilitation, I know Nola Injections is going to talk to you later in the week about pulmonary rehab. I do work closely with the physios in their rehab sessions, and the ones that they run from Heathridge are 2 sessions a week, and it runs for 8 weeks. So it's like that intense program, and after that maintenance week program is available for people. So So the idea is with those people that become deconditioned is to help them build those muscles up. It can be quite scary for them to be told to go out and exercise. So to be able to do it in a controlled environment with a physiotherapist there is fantastic and actually gives them confidence and also helps us to help them pace themselves. Often these people, because they know this task that they're going to do is going to be horrendous, they're going to get really breathless, they rush and get it done, and then they're exhausted, and that's it for the end of the day. We try and get them to pace themselves because they will probably be able to do a lot more. So polyrehabilitation is one of those things that really, really does make such a difference. I set up a support group about 2 years, just over 2 years ago. I've tried to make it now so that they're self-sustainable, so regardless of what happens to me with changes in government things that happen, they will run. So they're independent. So they're affiliated with the Lung Foundation, and it was pretty easy to set one up. They are so valuable to these people because it's such an isolating condition. People can try and understand, but I think unless you're actually living with the condition, you don't truly get it. And they do learn a lot from each other. So if you haven't got one in your area, speak to the Lung Foundation. They've got packs that can actually help you through those processes of setting one up. So we've got a chairperson and a secretary, and they sort it all out. I go along and I arrange the guest speakers for them. We have another specialist who comes every year, another pharmacist, a social worker, psychologist has talked about breathing and relaxation techniques. So it's anything that they want. We've kind of shied away from gardening and stuff like that. We don't think it's really appropriate, but no, it's a really good group and it's fun. So that's that lot there. We're not always outside having a barbecue. That was a Christmas do, so we have the boys outside doing the barbecue for us. And advanced care planning. We shouldn't be leaving these discussions until the last. The last stages of their condition. Advanced care planning is exactly that. It's thinking about ahead. What do the person want in the event that they can't make decisions for themselves? So where do they want to live? Or is there somewhere they desperately don't want to live? Or, along with that, so this is to identify future medical and personal care needs and preferences. So we encourage people to put their decisions in writing. Again, don't get them to put it in writing and stick it behind them. We're going to be making about it. So ideally, we want them to have this discussion with their family. And this isn't for everyone. Sometimes people just don't want to know, and that's fair enough. We can respect that too. But to actually give someone the power to be able to say what they want in the event that they can't make those decisions. These people are often in hospital with exacerbations. They might be on BiPAP and they can't make any decisions for themselves. If it's actually stated, I want to try and BiPAP, but I don't want to have artificial breathing, then that's their decision. All we try and do is to get them to speak to a specialist or GP beforehand, just so that we can cover all bases. So informing others. And if they have written a health directive, so that is the actual plan, which talks about what healthcare they do or don't want in those circumstances, then they should be giving a copy to their GP, their specialist, maybe to the hospital, their local hospital, so they've got it on record. This is what they do or don't want, especially if they don't want to be resuscitated. Power of guardianship is when they nominate somebody to actually make those health decisions for them. And if anyone's interested or wants to know more information, the website there is I've put up, it's really good, and this is one of the books they do, and they've even got an alert card in the back that people can put in their wallet if they've got advanced care plan. That's good to do. And power of attorney. So these people are only to do with money, financial side of things. But again, it can cause a lot of problems, so if people can have their requests or want to written down, it's not that problem. So other considerations, comorbidities. I've done some stats recently from, I've got 90 clients I see at the moment, and the most common comorbidity seems to be born with flux. Yeah, which is interesting. But it isn't just about the lung disease, they might have heart failure as well, and that can be impacting, especially in the later stages. Anxiety and depression is massive amongst this group trial. It's one of the top ones, but there's comorbidities. you've got a, no, I don't use PHQ. I tend to use a PHQ-9 score, which is a quick anxiety, quick depression score. There's several different ones out there, but that's the one I've chosen to use. It's quick and it's easy for the person to fill out, and it seems to be quite sensitive. And I've referred a lot of people to their GPs. It might be that they need some medication, or they just need to have some psychology for a few weeks. But it really is important, because if they've got depression or anxiety, they're not going to want to go to a you know, they're not going to want to go out and socialise, and that's when the condition can become a lot worse. Body mass index is really important. Those with a low BMI, it's likely to have poorer outcome. Same with the overweight people as well. That big abdomen is going to be making the breathing a lot more difficult, as is that extra weight they're carrying. So not always easy to incontinence as well. People coughing all the time could be incontinent, and that could actually be stopping them from going out, causing further isolation. So again, refer on to other services as needed. Certainly silver chain in this area, there are several continence management courses, but silver chain do have that support too. And these people might actually be eligible to receive some funding for Papps, because they're expensive, so without a pension. Activities of daily living, cleaning, personal care and transport. Is the person managing? Can they wash themselves? Are they not showering anymore? Are they not washing their hair? Often these muscles get very weak. And certainly when they go to primary rehab, they do strengthening exercise as well. One of the complaints from people is washing their hair. They get really breathless. So have they got a shower chair? Have they got rails in the bathroom? All those things are things that can help people. Something else that a lot of the patients find useful is to have a towel in a dressing gown that they can keep in the bathroom. So they get out of the shower, stick the dressing gown on, sit down and catch their breath. By the time they're recovered, they're dry, so then they haven't got to actively start drying themselves. So it's just little tips like that, and those are the sorts of things they learn from each other at the support group. So it might be that they need an OT assessment. We've also got to think about the carers. You know, it's really difficult for them as well to see their loved one suffering like this, but we also sometimes need to tell them to back off a little bit, because they see someone that's breathless, they just want to help and do everything for them. It's not in the best interest of the person necessarily to be doing that all the time. We want them to keep active and do as much as they can. But it might be that they need an ACAP assessment as well. So these are all things we need to be thinking about. And then palliative and supportive care. Again, you've got a session on this, so I won't go into it, but we had a teaching session a while ago, and there was a consultant, palliative care consultant, and she was saying, if you think, it's really difficult with COPD, because it's hard to put time on things, whereas cancer, you know, it might be a little bit easier to have some sort of idea of prognosis. But she says that if you think that person is not going to be here in the next year, it's reasonable to refer them on to palliative and supportive care, even if it's just for symptom control. And then they can be discharged again, but they will have met the team and they will understand the team. It's a process to support them. It doesn't mean that the end is now. It's that should be part of their care plan as well. Another thing to mention as well, going back to comorbidities, is osteoporosis. A lot of these people do have frequent courses of steroids, so they could be at risk of osteoporosis as well. So they might need to have some or other supplements. I've just put a list of tools up here that might be useful for you. I've actually given you all a copy of the CAT score, which is the COPD assessment tool. I found this really useful as well, and it's quite interesting. It seems to correlate. If somebody is exacerbating, it will go up slightly. But as a rule, it doesn't change too much. And I think it's 2 is the significant score change. Anxiety and depression scores, I said that I use the PHQ-9. Lung Foundation Australia is fantastic. They do COPD nurse online training. It's all there in Papps as well. And there's also pulmonary rehabilitation training they do. I think they also do some pharmacy training there. So they are a really good resource. And the COPDX plan is the Australia New Zealand guidelines for the management of COPD. So that's worth having a look at. And there are some condensed versions now, but it's a bit lengthy. So before I finish, I've got time, I just wanted to read this out to you. This is by a lady that had COPD. She's passed away now, but it's called Family Matters, and it's actually a letter to her family. She says, our lives may never quite be the same, AD, after diagnosis. In a perfect world, I wouldn't have COPD. We can both try to seek more joy, derive more pleasure from what we're fortunate enough to have, which is one another. Let's make the most of our time. In a perfect world, you wouldn't have to wonder how I was feeling or wonder what you might be able to do to help me. You wouldn't find yourself on the receiving end of my reactions to the episodic depression spells to which I am prone. Nor would you have to puzzle over the fact that I seem to have good days and then unexplainably so many bad days. You must be terribly disturbed by my shortness of breath and by my fatigue that nibbles at me all day, every day. And I can guess that you're upset and embarrassed, as I am, by the fits of coughing that sometimes seize me, especially out in public. You know that the compromises to my lifestyle that demanded of me are upsetting. It's hard for me to ask for help when I find I can no longer do something on my own. It hurts my pride, and I can see in your eyes that it hurts you too. But it isn't a perfect world, is it? I do have this disease, and so far there's no cure for it. I must learn to cope with it, we all must. So even though the world is less than perfect, particularly so since my diagnosis with lung disease, these issues do exist. I want to find a way to help you as you try to help me. That's why I'm writing this letter. Sometimes it's just easier to write things down than to say them out loud, especially things that cause this big lump in my throat even as I write. You're my loved and cherished family, and it seems to me that family members are often hit as hard with the realities of COPD as a patient, maybe even harder. It pains me to see you struggle with solutions for us as we fight the battle of illness together. I know you want to help. Our lives cannot help but be affected by the fact I have this disease, but I have learned that COPD is not a death sentence, nor does it have to be the end of our quality of life. The better I become at managing my own illness, the more effective and happier our time altogether will be. So that, I think, says it all. There's a lot that these people can be doing to manage their condition.